What we're going to concentrate on in my section is inflammation. Inflammation is the key to so many things: cardiovascular disease, degenerative conditions, cancer. Now, where I'm going to focus, because an area where I have some experience, is in the cardiovascular area. And I'm going to approach it from the aspect of carotid artery disease. But remember that atherosclerosis is a systemic disease. So whatever I talk about regarding the carotid artery can be applied to the heart and the rest of the vasculature. I performed vascular surgery for about 29 years. About 15, 20 years into my career, I became a little frustrated. Patients were sent to me for surgery. I'm screening them, and they're on 20 different meds. And I'm scratching my head going, this isn't right. So I slowed down my surgical practice some. I obtained a doctorate in natural medicine, and that got me where I'm at today. Natural medicine is not the entire key, but I like the ability to use both sides of the fence when I approach patients. And after doing surgery for 29 years, I moved into the field of age management. I've worked with Cenegenics for 6 years now, and we're going to take it from there. This topic is important as far as age management. The risk of stroke following a TIA when treated medically is high in certain individuals. And we'll get into those aspects. But where it also matters as far as age management is the age at which the disease is appearing. It's appearing at a younger age. The stroke incidence has increased. And if you look at the statistics, if you can read, 112,000 deaths and more than 262,000 cases that are disabled requiring long-term rehabilitation from cerebral vascular disease annually, it's a big problem. Now, we're all familiar with the Framingham criteria, developed years and years ago. This has been helpful. But a key here to look at is that a patient can fit the Framingham criteria as low risk. And statistics tell you that 20-25% of them fall through the cracks and have an unexpected cardiovascular event. And that's what I want to concentrate on today. How can we identify some of those that are going to fall through the cracks? Typically with carotid surgery, the key is having a 70% stenosis. A patient with a 70% stenosis in a carotid artery, if they have some sort of intervention versus medical treatment, a much decrease in the stroke rate. Now, a gray area here is how do you measure that 70% stenosis? The measurement varies depending on what modality is used and who the reviewer is of that particular study. And a very important aspect is it ignores plaque characteristics. And that's where I'm going to show you some clinical aspects of inflammation. This is the extracranial cerebral vasculature. You can see there is a rich bed of collaterals. What isn't shown here is the rich flow that comes from the external carotid artery. Now, this came to my attention, maybe 10 years into my career. I had an 87-year-old patient. I was aggressive with him. He was sent to me with a TIA because this guy was still living at home by himself and he was independent. I felt he deserved for me to be aggressive. Well, he was found to have a greater than 70% stenosis of one carotid. But as we worked him up, we found that the contralateral internal carotid artery was completely occluded, and the ipsilateral vertebral artery was completely occluded. Now, I performed the vast majority of my carotid surgeries under local anesthesia or regional block. So I assess patients while we're doing surgery, and we clamp the carotid artery during that portion of the operation to see how they're tolerating that. measuring their level of consciousness, talking with them, those sorts of things. Now, I went and I clamped his carotid artery on the side we were going to work on. So this guy is living off one vertebral artery. He didn't turn a hair. That carotid artery was clamped for 20 minutes while I did that portion of the operation. Didn't turn a hair. And it really got me to thinking about the significance of collateral circulation rather than just concentrating on this 70% stenosis. In the mid-'80s, we were developing ultrasound as a diagnostic modality for carotid artery disease. Angiography up to that point has been the gold standard. I was very interested in this. I became double-boarded in vascular sonography, and I was using the vascular lab in my office and looking over the shoulder of my tech and looking at these exams in real time. And it got to the point where I said, you know, this is giving me so much information, I'm ready to go to the operating room. The angiogram's not going to add anything more. Well, this was going against the current standard of care at that time. So I really started looking at plaques in the operating room and comparing them to what I was seeing on the ultrasound and trying to improve my judgment and make sure I was doing the right thing. Various modalities are available for determination of percent stenosis. The Doppler flow, we look at different waveforms, the characteristics of the waveform. We can also look at velocities, the systolic and the diastolic velocities. Those give us an indication of the percent stenosis. Now, if you look at this, first of all, you can see the difference. This is the common carotid artery waveform. There's an external, and here's an internal. They all look different. And if you see the external, there's what we call an envelope and a window present. You get into this internal carotid artery here, there's a lot of turbulence. That already tells me that there's some restriction of flow and causing turbulence. There's also an increase in the peak systolic velocity. That sort of a waveform is compatible with a 70% stenosis. This is the specimen from surgery from that particular patient. So you've got a 70% stenosis, but look at this part. That's a pretty ugly looking plaque. There's something else going on here. Now, here's another Doppler exam, and if you notice again, the turbulence, the loss of the envelope in the window, there's an increase in the systolic as well as the diastolic velocity. That's the sort of finding that you see with someone with a greater than 90% stenosis.